Hello, this video demonstrates the use of the antidromic snare technique for LV lead placement. We start off with a patient who had a previously failed implant using the traditional approach and tools. The initial venogram, it was difficult to see any target veins, but if you look carefully, you can see this very acutely angulated branch off the coronary sinus. We were able to engage the target vein utilizing a standard shape vein selector and actually able to get a wire into the vein, but could not get the wire deep enough to provide support to actually advance the lead or advance the vein selector. So at that point, the approach is to look for an adjacent vein that has collaterals to the target vein, and most frequently we use the middle cardiac vein. In this case, we've placed a vertebral vein selector into the middle cardiac vein and injected contrast to locate a collateral extending to the target vein. And you'll see here there's a very fine collateral that goes from the tip of the vertebral vein selector up into the target vein. So we were able to advance a 300 centimeter floppy straight polymer tip angioplasty wire through the collaterals back into the target vein and then back out into the CS. The wire that you use here is very important. It has to be very floppy and polymer tip, and the details of which are contained at the end of this video. So once we have the wire back in the coronary sinus, we insert a 4 French snare catheter into the coronary sinus as illustrated here, and then open the snare and then advance the wire into the open snare and then close the snare. Once we have the wire successfully snared, then we advance a microcatheter through the collaterals, having first, of course, removed the vein selector and replaced it with this microcatheter. Once the microcatheter is through the collaterals, we'll withdraw the snared wire into the sheath while we're advancing wire into the microcatheter. Once we've been able to externalize the wire to the point where we can have 80 centimeters of wire on the table in the pocket, then we can clip the snare free and advance the pacing lead over the wire. So the pacing lead is going in over the wire antidromic, but it's going into the vein in the normal direction. And you can see here we have the tip of the microcatheter here and the pacing lead being advanced. And then once the lead is in position and found to be tested satisfactorily, then we release the snare. First we peel the sheath away, then release the snare and remove the wire backward through the microcatheter. So the teaching points here is that there will be cases where you can't advance a wire or a lead into the target vein despite using any of the 3 vein selectors, in this case due to extreme angulation. However, we were able to advance out of the target vein into the CS by locating an adjacent vein with collaterals to that target vein. In this case, we used the Amplat support wire technique, and we're able to place the vertebral vein selector, easily engage the MCV, and once in the MCV, we located the target vein collaterals using contrast and then advanced the 300 centimeter wire back into the CS. As I mentioned previously, the type of wire is essential. It needs to be straight, it needs to have a very floppy tip, and it has to have a polymer coating so that it will navigate the collaterals. For this purpose, I find that the Choice PT floppy wire from Boston Scientific works quite well. I have limited experience with other wires. Your interventional colleague may suggest a similar wire, And the best way to address this, I think, is to ask them what wire they would use for opening chronic total occlusions in the arterial system using the retrograde approach. And then finally, before trying to externalize the wire, it is important to advance a microcatheter through the collaterals. Without a microcatheter, there is concern over the cheese cutter effect. So the wires and catheters and necessary, and as well as the snares, are listed here. I hope you find this useful. I know that it's a wonderful technique that you can use to avoid the need for an epicardial lead or a transeptal LV lead.